Assalamu alaikum and welcome to this first recorded message on or lecture on CTG interpretation. We will have two lectures on CTG interpretation. This one will focus how to recognize a normal CTG, and then the second one will look a little bit more at the abnormalities associated with CTGs or found on CTGs. This lecture we will have a look at a number of CTGs, and I would like you to take a pen and paper in your hand, and when there's the opportunity to have a look at the CTG yourself and recognize the features on the CTG yourself. So I will when the opportunity comes, I will let you know, but please have your pen and paper at your side for this. First of all, I need to move on this first slide like this. Okay, so let us start. What is a CTG? Yes, I think you can. You knew this. It's a cardiotocograph. Cardio stands for the fetal heart, toco for contractions, and graph that it makes a picture. So it makes a picture from the cardiac heartbeat together with the uterine contractions. Here you can see how a CTG can be monitored. On the left side, you see the usual CTG monitoring, which is done on the from the outside with a transducer. You see two probes on this picture. One is put on the fundus. It needs to be at the fundus because the contractions are strongest at the fundus, and this monitors the contractions and is labeled TOCO. There's a second transducer which is labeled US. It's a Doppler probe. It needs gel for functioning well, and it is put on the mother's abdomen to kind of hear the fetal heartbeat. During labor, it might be that the mother moves a lot, or so that the heartbeat is lost quite a while, quite a lot of the times. But you, as a doctor, you want a continuous CTG monitoring. Then it is possible to use an fetal scalp electrode, which you see on the pictures, two pictures on the right. It allows a kind of with a little little screw to kind of monitor the fetal heartbeat directly from the fetal scalp, and allows a monitoring a picture without loss due to movements or a contact of the CTG probe to the fetal heartbeat. So this is just to make you see that this is possible. So what is the purpose of a CTG? Why do we use CTGs? It is essentially the purpose is to monitor fetal well-being. We distinguish between antenatal and intrapartum CTGs, and you can maybe now think a little bit about indications for continuous fetal monitoring antenatally and intrapartum. Just jot down 3 indications for both, please. Antenatally, you use a CTG whenever you're concerned about the fetal well-being, but especially when there's bleeding, when there's reduced fetal movements or pain. The antenatal CTG, it is important that you realize that the CTG is only possible to be used reliably at 28 weeks and more in a pregnancy. Before that, the parasympathetic and sympathetic nervous system of the baby is not fully developed, and this will make CTG appearances different from usual. You might be able to use the CTG, but the interpretation is much more difficult. So what we are going to talk about in this lecture is generally concerned with CTGs that are taken at 28 weeks and later of gestation. So intrapartum CTGs have got a lot of use and are used very frequently. They can be used if intermittent monitoring has been abnormal, if in induction of labor to kind of monitor the baby's reaction to these contractions that are induced and also the frequency of the contractions. In high-risk pregnancies such as oligohydramnios, IUGR, preeclampsia, diabetes, prematurity, and also if there's sudden risks such as new onset of bleeding or anything like that, CTGs are usually used. But what can a CTG tell us? We have said already a CTG looks at fetal well-being, but what is it that a CTG can tell us? Actually, the best CTG can tell us is when the CTG is normal, meaning that abnormalities can have very many causes, and the CTG does not point us towards the cause. It just tells us there's something not quite right here, and actually nearly 90% of babies are absolutely fine even if they have abnormal CTGs. But a normal CTG is very reassuring, and it tells us that the baby is doing well at this moment in time. And this is the real benefit of a normal CTG, and this is why it is also very necessary to recognize when a CTG is normal. And recognizing a normal CTG also means that you will also recognize when a CTG is not abnormal or when a CTG is abnormal, and this is why we are going to focus on the normal CTG in this presentation. If you are not so sure about the CTG, or if you feel that there's an abnormality there, especially antenatally, then you can do a biophysical profile, which consists of amniotic fluid index, fetal breathing movements, gross body movement, fetal tone, and the CTG. All of these five points are put into one score. So one score is kind of made out of these five parameters, and then you can kind of gauge a little bit better. It gives a more detailed idea about how a baby is doing. And this is antenatally indicated when you have abnormal CTGs, or you have a high-risk pregnancy, or a pregnancy where you're worried about the fetal well-being. So let us look at describing a CTG. This is what we want to achieve during this lecture, that you are able to describe a CTG. What are the important characteristics of a CTG? Just write them down. First of all, there's the pattern of contractions. So whenever you look at a CTG, you have to also look at the pattern of contractions. Do you see contractions? Are they there or are they absent? And what is their pattern if you see contractions? Then you look at the baseline. You look at the beat-to-beat variability. You have to see if there are accelerations present on the CTG, and finally also if there are decelerations present on the CTG. And this is and we're going to talk about all of these features that you can find on the CTG in this and also the next lecture that I will be recording for you. So when you interpret a CTG, it is really important to follow a pattern. This is important because otherwise you are likely and prone to oversee important details. Therefore, you should always follow a pattern which will allow you to look at all of the important features that a CTG displays. You also should never look at the CTG in isolation. You have to look at the CTG in the context of the risk that the patient has. Also in the clinical context. So, is this an antenatal CTG or an intrapartum CTG? What is this patient low risk? Is she high risk? So that you know how to interpret a CTG appropriately and what actually actions to take in response to a CTG. You have to assess contractions, I've already said that, and after you've assessed the contractions, you then look at all the fetal parameters that we have just discussed, and we'll go through all of them one by one in the following of this presentation. So that you can remember to look at all of the features of a CTG, there's an abbreviation called Dr. C. Bravado. And you can see it is listed what it stands for. Doctor means to determine risk. Is this patient low risk or high risk? C means contractions or patterns. So are contractions present? And if they are present, are they coordinate, incoordinate? What is their duration? BRA means baseline rate. V, variability. A stands for acceleration, D for deceleration, and finally O for overall assessment and plan. In obstetrics, it is always important, after you've made an assessment of a patient, to also formulate a plan and write this plan in the notes. This is necessary as plans or situations and conditions change quickly in obstetrics, and every change in a patient's condition also requires a new plan. And this is very important to document these plans into the notes so that the team knows what the plan is for this patient at the moment, and if it changed, it needs to be updated. So when you describe a CTG, you want to first of all look at the clinical situation and what is important to look for. How low risk and high risk, I already said that. So you want to look for example, has this patient got intrauterine growth restrictions, oligohydramnios, diabetes, preeclampsia? Is she premature? Is it a prolonged pregnancy? Have you got bleeding, pain? Did she complain about reduced fetal movements? So there's a number of things you want to look at within the clinical situation to inform how this CTG relates to the patient's condition and what becomes necessary to do for her. Secondly, you look at the pattern of the contractions. Are they absent? Are they present? Are they regular, irregular? And we already said that. So if you look at this CTG, you can see some letters at the right side, A, B, C, and D. Just write down what A, B, C, and D represent on this CTG. I give you just half a minute to, or not even half a minute, quarter of a minute to write these four down, what they represent. So let us start at D. What is D? D is the line where you can see contractions. In this CTG, there's no contractions. This patient has no contractions, so she is not in labor. C, you can see these little squares on the CTG. They represent fetal movements. Fetal movements that the CTG machine notices and marks on the CTG. Not all CTG machines do this, marking fetal movements, but a number of them do. B represents, you can see kind of marks on the CTG. And these marks are made by the patient herself. She's given a kind of little button, and she's told, for example, as in this CTG, whenever you feel a movement, kind of a mark, press the button. And this is what she has done. So these are also represent fetal movements, but these are those fetal movements that the patient felt herself. And finally, you find A, and A is the fetal heart kind of pattern that the CTG kind of documented for this baby. So let us go to the details of description of the CTG. Let us first of all define what is normal. Baseline should be 110 to 160. Beat to beat variability, less than 5 is abnormal for beat to beat variability, and it should also be, and also above 25 is abnormal. However, beat to beat variability, and I'm going to show you some pictures what it represents. Beat to beat variability is an expression of the parasympathetic and sympathetic nervous system, and this is not new. So the patient, this system is not mature before 28 weeks usually, and therefore below 28 weeks, if you do a CTG for a baby below 28 weeks, the beat to beat variability might be reduced, but this might be normal for this baby due to their maturity. Accelerations are at you should see at least 1 in 20 minutes. This is an increase for at least 15 beats per minute for at least 15 seconds in the CTG monitoring. And it is usually associated with fetal movements, and it is the single best indicator for fetal well-being. So if you see the acceleration on the CTG, this is very reassuring. Finally, you see decelerations, and these are absent. You see in the normal CTG. So a normal CTG by definition has no decelerations, but it is kind of a mirror image of the acceleration. So it is a decrease from the baseline of 15 beats per minute for at least 15 seconds. So if we look at the CTG, you can see that these different phases are kind of labeled for you. At the bottom, you can see this patient has got contractions, and they do look that that they are regular contractions. You can see even a kind of a marking of movement on this CTG, which is not labeled here. You can see a monitoring of maternal pulse. This is not available with most CTGs actually, but it is in this CTG, and it can be helpful, as it is sometimes possible to mistake the maternal pulse for the fetal heart rate, and this is of course shocking because the fetal heart rate is above 110, but the maternal pulse should really not be above 80. So then you think, there's a deceleration, and you kind of fear, but in fact what you listened to was the maternal pulse instead of the fetal pulse. So it can actually be helpful to have maternal pulse monitored to compare with. And finally, you see the fetal heart rate is kind of looked at, and you can see 2 accelerations are labeled on this picture, and you also see the variability is labeled, and the baseline rate, you see a green line going through that. You see something else labeled on this CTG, which means the time of 10 minutes. And this is important in a CTG. 10 minutes represents 10 large squares on this CTG machine. And this is because we always look at contractions. When we evaluate contractions, the number of contractions in 10 minutes. So in a normal labor, you should have 3 to 4 contractions in 10 minutes. And this you can kind of count easily on a CTG when you know what represents 10 minutes. Usually, and you can see this here as well, there's a number of rows of lines of numbers. No, it's not so, yeah, of numbers on the CTG that kind of represent 10 minutes. So every 10 minutes you get some numbers on the CTG at the contraction part. So let us look at the baseline now. Here the baseline is pretty obvious. You would start, you can see it, but you cannot read the numbers. And I'm sorry for this. In many of my pictures, the numbers are not recognizable on my pictures, as I kind of needed to increase their size, and this made it difficult. So if you follow the CTG pattern, unfortunately, we have to look at CTGs in isolation here. We do not know the background, the patient, where they come from. But here, if we just look at the CTG, you can see first the contractions. You see this patient has contractions, and here you can see within 10 minutes from one line of row of numbers on the contraction monitoring to the next, there are 10 minutes, and you see 4 contractions in 10 minutes. They are sort of regular, although before then she seems to have a phase of irregular contractions. So we might need to have a look at a longer CTG monitoring for this patient. If we then go to the actual fetal heart rate monitoring, we can see that this patient has a baseline. This looks like a baseline of around 110, but I'm guessing this from here. The variability appears normal, and we will look at this later on as well, a little bit closer, and you cannot see any decelerations or accelerations on this CTG. So this is another illustration of how you can see the baseline. At the bottom monitoring, you see the contractions. This patient has contractions, but again you see number lines going through the contraction monitoring, which mark 10 minutes, and here you can only see 2 contractions in 10 minutes. And further up, you can see the fetal heart rate monitoring and the baseline, which is around 110 in this picture. This is a drawn picture. It's not a real monitoring. And this also shows a normal variability. So the baseline should be 110 to 160. In this CTG, we already said there's no contractions. If we look at the heart rate baseline, it's also a normal baseline. It appears to be around 120 to 130. And variability is normal, and you see accelerations here. You see 1, 2, 3, 4 accelerations on this CTG, but you do not see, there's no decelerations on this CTG. There's no decelerations visible. Okay, let us look at the next feature of the CTG, which is the beat-to-beat variability. As I said before, less than 5 is abnormal, and so is more than 25. The beat-to-beat variability is meant to be the peak, the little squiggly, if you look at the baseline, the little up and down of the CTG of the baseline, and it is the number is between the peak and the trough of this feature, and here you can see it marked. This is the variability, and on this CTG you can see a normal variability, and you can also see several accelerations again. Here is also a variability marked, and you can see even they've made an attempt to kind of actually measure it and put a number to it and come up with a variability around 20. This is also another way where you can gauge variability, and this is what many people do. they look at marked, they look at the CTG like that and say, this has got marked variability, moderate, minimal, or absent variability. Absent variability really means this is a dead baby, and represents a dead baby. Minimal variability is for a long period of time, is very concerning, and it's a pathological feature which needs immediate action, and we're going to talk about this in our second CTG lecture on interpretation on pathological or abnormalities, interpretation of abnormal CTGs. Moderate and marked variability in this CTG are actually normal. Accelerations. You should have at least one acceleration in 20 minutes. It's a marked increase of 15 beats per minute for at least 15 seconds. And it's the single best indicator for fetal well-being, as it is associated with fetal movements, and only those babies can move which have enough energy and are healthy enough to actually move in the maternal body. Here you can see accelerations on the CTG, and they are you can in the middle of the CTG you can see a fine looking accelerations, followed kind of 4 minutes later by another one, and then 5 minutes later by another one. These are very good features. Decelerations, of course, should be absent on the normal CTG. This is a decrease of 15 beats per minute for at least 15 seconds. We are only going to go over them briefly today, and we are going to look at CTGs in the second CTG lecture a little bit more. So we are going to look at CTGs that have decelerations in the coming lectures a little bit more. But we generally distinguish between early, late, and variable decelerations. An early deceleration is a deceleration that starts with the contractions, that has its nadir, its lowest point with the contraction, and that is also recovered with the contraction. It's actually a mirror image of the contraction. This here you can find an example for early decelerations. In fact, early decelerations are very rare to find. They you will hardly see them on a CTG. They are an expression of what? That's right, they are an expression of fetal head compression and are a benign feature on the CTG. So they do not represent a major abnormality. The CTG on this, so because they are represent fetal head compression, they usually occur in the advanced stages of the second stage. So in the advanced phase of the second stage, when the baby is deeply engaged in the maternal pelvis, and this is of course therefore they are not so common as other forms of decelerations. Late decelerations, on the other hand, usually start on the top of the contraction when the contractions is the strongest, and then the deceleration occurs, and then it takes a long time to come back to the baseline, to normal, after the contractions. These are a pathological feature that is worrying, and that shows that the baby has got a reduced reserve, fetal reserve, so that the fetus has got a reduced reserve and cannot compensate with the contractions very well. It basically shows that the contraction, during a contraction, the blood flow to the from the placenta to the baby gets interrupted, and in a healthy baby this can be compensated well, and you do not even see it on the CTG. So well do babies cope with this sort of interruption of blood flow. But in those babies that are compromised and that have a reduced fetal reserve, in those babies you will find decelerations, because their compensation is delayed, and it is very worrying if they show late decelerations, because this is exactly the delay in kind of coming back to normal and compensation after a contraction that shows the baby is actually not well. This is our late decelerations. I'm sorry, but you can just see a slight kind of going down of the CTG. This is on the whole, just to kind of put the CTG into context, on the whole, this is a very worrying CTG. It not only shows late deceleration, also the variability is reduced, and this is a very a CTG of quite a compromised baby. Here's another CTG of a late deceleration, and you can see the deceleration is well below, well behind the contractions. And again, you see late decelerations, they occur after every contraction. Finally, we talk about variable decelerations. Variable decelerations are the most common type of decelerations that you will find. Variable decelerations are are decelerations that occur which are not related to the contractions. Okay, so you will find them during a contraction, after, before a contraction. There's no clear pattern visible in the CTG to describe the deceleration, other than that it is variable. You might often find a little shoulder at the onset, and you can see it marked here. You can see onset of deceleration, so you can often find a little shoulder there, and then it goes down. And also at the recovery of the deceleration, you often find a little shouldering, and which are good signs. Actually, they show the fetus actually well compensated. Okay, so we're going to talk about variable decelerations a little bit more in our next lecture. But this is a picture. Here you can see variable decelerations. They are not really showing a very good pattern along with the contractions, but they happen here and there. And you can see also the feature of the little shouldering in front of every of the decelerations. So if we now look just at a few examples of CTGs, please take your pen and paper and follow Dr. C. Bravado and kind of explain this CTG. I give you a couple of seconds for that. So here if you look at the contractions, you do not find contractions or regular contractions on this CTG. You find maybe a singular contraction and then another singular, but they are not really, they might just be tightenings. Above that, you see the fetal monitor actually documents fetal movements. And further up, you see the fetal heart rate monitoring, and that shows a normal baseline. I cannot see the exact number, but it looks around 130. It shows normal variability, and you see several accelerations on the CTG. 2, 3, 4, 5, 6, 6 accelerations you will see on the CTG, and no deceleration. The last acceleration, which is a little bit longer, if you go down and look at the stripe where this monitor monitors the fetal movements, you can see that this longer acceleration is actually associated with fetal movements a lot more compact, so more fetal movements. And this is very typical for accelerations. It represents the same mechanism as when you go to the bus, taking you to Emirati Hospital in the morning, and you find yourself late, so you run a little while to the bus. Then you also have your heart rate will also be fast when you reach the bus, and this will and this is the same for the fetus here. The fetus, when it moves, it kind of translates into a tachycardia, a little boast of increased heart rate. So this is another example of a CTG. When we look at the the contraction pattern, we see that this patient has got sort of regular contractions, but they are quite frequent. So you can count 7 contractions in 10 minutes. This is actually frequent, and it makes you wonder if it's more like tightenings rather than contractions. To distinguish this, you will have to have a feel of the fetal of the contraction. So you will have to examine the patient, put your hand on her abdomen and feel the contractions and feel what they are. Also see if they are painful or not, and what effect they have on the cervix. Does the cervix dilate or does it not? Then if you go up, you see the baseline around 140, possibly a normal baseline, normal variability, but you cannot really see clear accelerations or decelerations on the CTG. We've already looked at this. So in the at the end, I want you to remember again Dr. C. Bravado. This will help you to look at every detail of a CTG and not to forget any of the features and details that that you can find or that you should find on the CTG. And it makes you remember to put the CTG into context, and also to make an overall assessment and plan for a patient when you reviewed a CTG. So in summary, I have 2 points after this lecture. Be systematic, use Dr. C. Bravado for this. Once you kind of have looked at many CTGs, you will not remember, have to remember Dr. C. Bravado, because it comes natural to you to look at the CTG in this way. A reactive CTG has 1 acceleration in 20 minutes and is very reassuring. It will be it will be you will be happy to see a normal CTG, and it will be the one indicator or way to know that the fetus actually at this moment is doing well. And I want you to say I wrote 2 accelerations, but actually it's 1 acceleration in 20 minutes. Thank you very much, and we will later on have the CT look at the we will later on look at the abnormal CTG in the next presentation.